Just for this opportunity. My topic for the next 15 minutes is approach towards accepting a diabetic or a hypertensive disease donor in our clinical practice. I have nothing to declare. This is my talk at a glance. I will be telling you briefly on supply and demand in the world and India, and I will review the literature on the disease donor diabetes and hypertension, and I will touch upon the role of kidney biopsy in these type of patients and it will come to conclude. So if you look at the organ demand and supply, we all know there is a huge demand and the supply is less. It is the UNOS registry, if you look, then about almost 1 lakh patients are on waiting list, and if you take every 8 minutes, another person is added to the waiting list, and about 17 people die each day waiting for an organ transplantation. So the patient on waiting list is constantly increasing by about 10% annually. And in spite of doing the renal transplant at about 4% every year, there is still a gap and it's widening every year. So as far as the average waiting period for a cadaver graft is more than 5 years in United States. So if you look at the organ wise, there is a huge gap in the kidneys. So there is a huge gap in the kidney wise and the US compared to the other organs. So as far as India is concerned, it is no exception. As far the Indian data is concerned, approximately 1,75,000 to 2 lakh kidneys people are waiting, and not even 10% are getting it. So if you look at the scenario in us, the live is more than the diseased. If you look at as from 2013 to 22, there is a significant increase, both living and disease, but disease remains almost a constant. If you look at the disease donation rates, it is less than 1 per million population from 2013 to 21, and to become self-sufficiency, we need at least 62 per million population. So there is a huge need for the cadaver organs. So why we need for the marginal disease donors like diabetes and hypertension to be included and to be considered in each and every patient we come across? There is a huge organ shortage. And diabetes and hypertension per se is highly prevalent in the population. If you look at present, about 8 to 15% are contributing for the organ donors, especially disease donors, the diabetes and hypertension. Because of the high prevalence of this diabetes and hypertension in the community, maybe after 10 years, at least you can say 20 to 30% of our disease donors will be either have a diabetes or hypertension. So it's our duty to identify a potential suitability among the diabetes and hypertension donors and match them with the appropriate recipient. And then the most important thing is just excluding the donors solely based on the diabetes and hypertension status may raise ethical concerns regarding the fairness and equity in access to transplantation. So if you look at these donor factors that can influence the graft outcomes in our cadaver, so if you take the red ones, that's the one which have some evidence, that objective evidence for risk to avoid those them, like either diabetes or hypertension. So both hypertension and diabetes, which I am going to talk, will have some evidence to say that the graft survival and the patient survival may not be good compared to a standard criteria donor. So coming to the donor diabetes, if you take the US registry, every year about 8% of the disease donors have diabetes. And among which, in spite of whatever their extended criteria to include them, 40% of the kidneys from diabetic donors are still being discarded. If you look at the kidney allocation system implemented from the 2014 in US, that is the KDPI index, there it contains 10 donor factors. The donor diabetes carries a heavy weight. So that's also an important reason for discarding of the donor kidneys. So coming to the literature or evidence, when I looked into the diabetic donors, whether to take or not to take, what is the evidence, most of them are retrospective and they are all registry based, mainly the UNOS registry, and very little data from our country. So I will just go through a couple of studies. This is the study from Mohan et al., where it's basically on the UNOS data-based study. They took about 1982, the recipients of diabetic standard criteria from the about 10-year duration. There they took the diabetes with the standard criteria donor and compared with that of the extended criteria donor with both diabetes and non-diabetic. If you see in this graph, The top one is the standard criteria donor with no diabetes. The second one will be the standard criteria donor with diabetes. The third and fourth, which are below, are the ECD non-diabetic and ECD diabetic. So what I want to emphasize is in this study is a diabetic donor with the standard criteria is better than an ECD without diabetes and still better than a patient with ECD and diabetes. Whereas the Cohen et al., which is been published in 2016, again from the UNOS registry, where they compared the diabetic versus non-diabetic. Here they have taken diabetic as a one pool and non-diabetic as the another pool. When they compared with the all graft failure and the death, if you look at the graphs on the left side, there's very clear that the donor with diabetic status will not do well as far as the survival of the graft as well as the patient survival. So they further subcategorized into non-diabetic donor and non-diabetic recipient, diabetic donor and non-diabetic recipient, and non-diabetic donor with a diabetic recipient, and diabetic donor with a diabetic recipient. Even with that, if you look at the other side of the graph, there is a clear cut that the non-diabetic donor with a non-diabetic recipient will do well compared to the other forms of grouping. So see, in that there is no clustering like which organ to be given to the which group of patient may do well. So in the recent publication in 2023, where they used artificial learning, so basically what they did is all diabetic disease donors, and they clustered the recipients into cluster 1, 2 and cluster 3. Cluster 1 are the one who has have less what you can say survival, like oldest age, highest rate of comorbid diabetes mellitus, and they are received the organs which had bad kidneys like hypertension, and the ECD status was about 78% and high KDPI. Cluster 2 are the younger donors with, but they are high risk immunological profile and with the second transplant, and cluster 3 are the one which have been well kept and first kidney transplantation, and they received the graft from the younger donors. When they made these clusters, what they identified was then the cluster 1 people didn't do well compared to cluster 2 and 3 in spite of all receiving the diseased diabetic donors. What I want to emphasize in this is if we can allocate to a proper group like the cluster 1 who are bad and they have a less survival, then with the kidneys which is being diabetic and with high KDPI kidneys with other comorbidities, then the survival means it will be appropriate allocation to the recipient. So all these things evidence says that the standard criteria donor without diabetes will do fare well compared to that of the diabetic with SCD or ECD. When they compared them with that of the remaining on the waiting list, this is the Cohen et al., the same group, the same population, they again divided and seen with a critical question whether waitlisted patient should accept diabetic donor kidneys versus waiting for a better kidneys. What they found is having a kidney with a diabetic donor offers a great survival benefit compared with that of the remaining on the waiting list, and especially patients with high risk of mortality on the waiting list at centers and with long waiting times appear to benefit most from transplantation instead of waiting on the waiting list, waiting for a better kidney. So to nutshell, as far as the diabetic donor is there, like they do well compared to the ECD or ECD with diabetic. But when compared to the standard criteria donor, their survival and the graft outcome may be lesser. But majority of the evidence shows that when compared to waiting lists, they are better. When coming to the donor hypertension, when I research the literature, there is very less data as an individual thing as donor hypertension, but majority will be as ECD because it is one of the component of the extended criteria donor. So I'm going to tell you about two meta-analyses for the donor hypertension. The first of the one was published in 2019. It included 12 studies which are shown there, and they compared with the allograft failure and mortality. What they found is having a donor hypertension in the deceased donor had a less graft function, but there was no change in mortality. Again, and another meta-analysis with 29 studies where they compared ECD with SCD. ECD included the hypertension fellows. If you look at the table, the ECD did not do fare well compared to that of the standard criteria donors. Again, when come to the hypertension, when they compared marginal cadaver donor kidneys with had a hypertension with that of the other recipients who are on waiting list, the life expectancy of having a marginal donor had better compared to that of having in the waiting list by about 5 years. So, which subgroup with significant survival benefit can get by getting a diabetic or hypertension or ECD donor kidney transplantation will be patients older than 40 years and long median waiting time, patients with diabetes or hypertension, patients with low immunological risk, and our dialysis patients with vascular access problems with a less life expectancy and who may not do well on waiting for the kidney transplantation. When I looked into the literature for the other organ transplantation, there is less literature. Of course, when I looked into liver and lung, there is, when the compared to diabetic, non-diabetic, there were inferior outcomes. One of the studies in cardiac had a similar outcome, irrespective of the diabetic duration of from 0 to 5 years or 6 to 10 years or more than 10 years. Thus, there was a similar outcome as far as the cardiac transplantation is concerned when the deceased donor was of a diabetic. So coming to the last part of my talk to tell about what will be the implication of doing a pre-implantation kidney biopsy in this type of patient. When I looked into the literature, there are a couple of studies where they did biopsy in the diabetic patient pre-transplantation and protocol biopsies, and at the end of 1 year. What they found is a small percentage of diabetic donors will have DKD, means usually it will be class 1, maximum 2A. And if there is no diabetic nephropathy in biopsy, very unlikely they will have diabetic nephropathy even in follow-up biopsies. And if they had early changes of diabetes in the biopsy, even when they followed up, it was a slow progression or it will be stabilized even of the follow-up of the patient. So what they suggested is that diabetic donor kidneys, whether with or without diabetes, may not by itself an impact significant adverse effect of the graft survival. There are another study from the Gilbert et al. In that, the important highlighting features are, the one thing they found is duration of donor diabetes for more than 6 years and will have an impact on the graft survival. And also when they looked into the histopathological data, having a more vascular changes than that of the glomerular disease, and degree of arterial hyalurosis and IFTA decided the prognostics in those patients for the graft loss. So, role of pre-implantation kidney biopsy, it started with 1999 with the Karpinski et al. And then by the Remuzzi et al. What they did is histologically scored the ECD kidneys on the severity of the chronic changes. Scores were given from 0 to 3 of each component, that is the 4 components, vessels, glomeruli, tubules and the interstitium. The total score was 12. So if 0 to 3, the kidney will go to the appropriate recipient, 4 to 6, it should go to a dual kidney transplantation, and more than 6 discard. Similarly, Perico et al. Has come out with another algorithm. It's almost similar to the previous. When the marginal kidney donors are there, age more than 60 years, history of diabetes or hypertension, and a significant proteinuria, if there is no major vascular or ureteral or parenchymal abnormalities, you should consider them for a pre-transplant biopsy of both the kidneys, and eligibility for double or single transplantation according to the scoring system. Again, it's the same, 0 to 3, there's mild changes, you can go ahead with the transplant. 4 to 6, consider for a double or dual kidney transplant, and more than 7, discard the organ. There was a study from our Kochi center in the India where they shared the deceased donor transplantation experience in the last 4 years. And in that, they did the biopsies in their cadaver program for the marginal donors. And the definition was, as I told there, with diabetes with less than 500 milligram, and then proteinuria, presence of hypertension, renal calculus, or more than 60 years, or more than 55 years with the ECD criteria. So what it helped them having a biopsy is, among the 20 when they biopsied, when they have a dilemma whether to take the kidney or not, after the biopsy they have decided to go ahead with the transplant in 16 out of them, and it had a good outcome. So pre-implantation biopsy should be considered in marginal donors. As far as the OPTN guidelines, when I looked into any guidelines as there for a standardized kidney biopsy in the deceased donor program, there was not much. There is a public comment proposal put in the OPTN in 2023. It gives certain criteria to decide on the kidney biopsy in our deceased organ transplantation program. With that, few of them are the history of diabetes with an HbA1c of more than 6.5, KDPI greater than 85%, and even the ECD criteria with history of hypertension. To conclude my talk, studies have shown that while transplant from marginal disease donors like diabetes and hypertension may have slightly lower graft survival rates compared to the standard donors, but the overall outcomes are still good and acceptable compared to being in the waiting list. Use of a diabetic and hypertensive donors for kidney transplant increases the donor pool, and of course it results in shorter waiting time for transplantation. It limits morbidity and mortality associated with the long-term dialysis therapy. History, clinical and proper biochemical parameters when we get a diabetic or a diseased donor to look for end organ damage. If not there, you can proceed with the transplantation. If needed, kidney biopsy should be done, and even dual kidney transplantation option can also be thought of before discarding the organ. And appropriate recipient allocation may give better results. Thank you.